Hello again, it's me again, Hany Ragy, and we're going to discuss what's new in the 2017 ST segment elevation myocardial infarction and in the dual antiplatelet therapy guidelines, the DAPT, in the 2017 ESC guidelines. There has been some changes in the 2017 STEMI guidelines of the European Society of Cardiology. So to summarize everything in one slide, it's pretty easy. How it goes. The yellow color means that you can do this. The red color means that you can't do this. The green color means that you should do this. I'll say it in Arabic as well. لما تبص على السلايدز عشان تعرف الجايد ده ملخص كل الجديد اللي هيتقال في النص ساعة اللي جاية في سلايد واحد. اللون الأحمر بيعرفك إيه هو الميديكال براكتس اللي يفضل إنك ما تعملوش أو بلاش تعمله. اللون الأصفر بيوريك الحاجة اللي ممكن تعملها. واللون الأخضر بيوريك الحاجة اللي أحسن تعملها أو لازم تعملها. بنشوف الفرق بين الجايد لاينز القديمة 2012 والجديدة 2017. So what's the difference between the guidelines in 2012 and 2017? Looking at the axis. So how are we going to get into the vascular system in a STEMI case? In 2012, the radial axis was yellow, meaning you could use it, and you could use femoral. In 2017, the radial axis is green, which means you should use this. You'd better go radial, because we know, and we'll show in a minute, that radial in STEMI might save lives by reducing bleeding. The second one, where there was a change, is drug-eluting stent, DES, over BMS. In 2012, you could use DES, it was yellow. In 2017, you must use DES in STEMI based on the names of the trials that you see in front of you, the examination trial, the comfortable AMI, and the NorStent trial, and others. So, the third point, complete revascularization. In 2012, you know what? If you did complete revascularization, you might have been penalized. You couldn't do it, it was red. But look, in 2017, you could do it. You know what? It's preferred to fix all the arches, all the important arches that you're sure are causing ischemia during the time of the index event, or a day or two later, possibly using FFR. And you have the trials, the PRAMI, the DYNAMI, the 3-Primulti, the culprit, and the compare acute. So a lot of evidence showing that you can do complete revascularization in STEMI is not wrong anymore. And that is the beauty of evidence-based medicine, that nobody can rely on you don't have to rely on your own experience. You rely on the collective experience of the whole medical community in large trials, which show us all which is the best approach to our patients. So what about thrombus aspiration? Putting a little straw in, sucking the thrombus out during a STEMI. It sounded like a good idea, and based on small trials, and it was recommended in 2012, yellow, not a very strong recommendation. So what happened in 2017? We now have 2 big trials which show that this is not a very useful thing and is not recommended in routine practice. However, you can still thrombus aspirate if you individually have the experience and you feel that it's going to be good for your patient. It's not something which you are stopped from doing, but you are definitely stopped from routinely doing it. So what about drugs? We have 2 important drugs in which there was a guideline change between 2012 and 2017. One of them is bivalirudin, the Angiomax. Bivalirudin was very popular in 2012 because it was thought to reduce bleeding while maintaining a good anti-ischemic protection, antithrombotic protection. And what happened? We have 2 trials, the MATRIX and the HEAT primary PCI, which show that because we use radial and other things, bivalirudin is not that useful and is gone to yellow. So if you want to use this expensive drug, you can, but you don't have to. You can just give heparin and probably get away, because with the stronger newer antiplatelets like ticagrelor and going radial, you don't get that much bleeding with heparin anymore, and you get very effective therapies, so it's gone from green to yellow. What about enoxaparin, the famous low molecular weight subcutaneous heparin? It was orange in 2012, meaning, orange is even worse than yellow. So orange is the lower grade of yellow, nearer the red, meaning you could barely use it. But in 2017, because of the ATOL trial and the large meta-analysis showing that you can use enoxaparin in STEMI patients, so it's gone from orange to yellow. We come to the last 3 points. Early hospital discharge was almost a no-no. It was orange in 2012. We now have small trials and observational data showing that in selected patients who do extremely well in STEMI, you can discharge them early, and they do well. And we all know that keeping in patients in hospital longer than they should is associated also with other problems and costs. We come to oxygen. Oxygen is still there and is still green, but the level of the PO2, this oxygen saturation, has gone down. You used to have to give oxygen if the saturation, the SO2, was less than 95% in 2012. In 2017, this has gone down to 90%, and based on trials again, the AVOID and the detox trials. So if your patient has a SO2 on room air of 92, you do not have to give them oxygen in 2017. In 2012, you would have to give them oxygen. Finally, if you're going to use thrombolysis, you're going to use the TNK. The same dose was available for all patients in 2012. In 2017, we know it's safer to give half dose to the elderly patient, and that definition of elderly was the one used in the STREAM trial, which was 75 years of age.